I'll let Paul tell us how good he is as an introduction to his speech, but very briefly, Paul is the director of the Ingham Institute of Translational Cancer Research Unit. He is a professor of medical oncology at University of New South Wales, University of Western Sydney and Liverpool Hospital. In 1997, he founded the Clinical Trials Unit in the Cancer Care Unit of the St George Hospital, as well as a research laboratory dedicated to developing new drugs and approaches for the treatment of prostate and other urological cancers. Now, if all of that's out of date or totally irrelevant, we'll leave it up to you, Paul, to correct us on that. But please make welcome Paul de Souza. Thanks, Paul.
To kick off, I've got about 20 or so slides about some biomarkers in prostate cancer, which is a hot new topic for many researchers over the last few years. One of the problems is that prostate cancer is not just one disease, and you've probably heard this before, it's many diseases. So in one man it'll behave very indolently, and in another man it'll behave extremely aggressively, and then all the shades in between. So it's difficult to know or have any idea about when someone turns up in your office how that person's going to go. So there has been a lot of focus and a lot of interest, particularly internationally, about trying to develop a set of biomarkers, what we call biomarkers, that might give us some idea of how an individual patient with prostate cancer might travel. And the reason for that is not because we want to tell the future, because we can't, obviously, but so that it might help us decide at an earlier stage, okay, well, look, we'll be very aggressive about this man's prostate cancer, whereas we'll hold off on this man's prostate cancer. This man will be suitable for hormones, whereas this man is probably not suitable for hormones. We might try something else. It's also very useful for clinical trials, and there are a whole lot of clinical trials nowadays in prostate cancer, especially over the last 10 years or so, developing new drugs. All drugs are not the same, and all prostate cancer is not the same, so in order to give that drug the best opportunity to work, it's best to define your patient population. So that's the idea behind trying to find biomarkers. So a biomarker, and my apologies, I stole these slides from someone and I can't remember who they were, so I can't properly acknowledge where I got them from, but they're a little bit technical, but I'll skip over that. So biomarker really is something, a measurement, if you like, that might be able to predict how a man responds to treatment or how aggressive their prostate cancer is. So that could be as simple as their body weight, that might be a biomarker, or it could be as complicated as circulating tumour cells, which I'll go into a little bit down the track. So there's a range of potential biomarkers that might explain how men go with prostate cancer. And over the years, you would know the development of PSA, prostatic specific antigen, as a very good biomarker for prostate cancer. Unfortunately, it's not that accurate, it's not that sensitive, and it's not that specific. So we can't use it to diagnose men with prostate cancer. However, the majority of men do overexpress PSA, so you can use it to follow and see what happens in a treatment journey. So in a sense, that's a very good biomarker, and it's been around obviously for many years. The types of questions that we try to answer from biomarkers are things we call prognostic or predictive. And the blue circle represents a research area, if you like, trying to answer the question, is this patient likely to develop this particular cancer? And obviously in men, we're talking about prostate cancer. So there's another question to that, and it is, once having been diagnosed with prostate cancer, how well will that man go? What is their prognosis like? Hence the word prognostic. At the other end of the slide is a predictive factor. And predictive factors are factors that might tell us how well a man responds to a particular treatment. So hormones are used very commonly, chemotherapy as well, once men fail hormones. And so you might want to know beforehand, what is it about this man's prostate cancer that might predict them to do better on chemotherapy or to do better on hormones? That's a predictive factor, which is different to how long will this man live. You know? So to give you an idea of the difference, prognostic factors is a bit like life expectation at birth. Everybody is born, and then at birth there's, in Australia, the average life expectancy for women is something like about 82 years, and for men is something like about 78 years. So everyone that's born in Australia, that's their life expectancy. That's the prognosis. All right? But the predictive questions is, okay, having seen that child go through teenage years, is he going to become a fireman or a lumberjack or you know, a surfer? What are the factors that might predict for that type of behaviour, if you like? That's the difference. Then there are other questions that we might use biomarkers for. For example, the purple circle represents recurrence. Having had prostate cancer and it's been treated with surgery or radiation, what is the likelihood that this particular prostate cancer might recur? So what factors might predict for recurrence? Equally, you might use biomarkers for pharmacodynamics, and really what that means is that if someone is given a drug, we don't know how that drug behaves in an individual. So someone might tolerate chemotherapy extremely well, for example, and their brother might tolerate the same chemotherapy at the same doses horribly. So what is it about that particular person? Is it their weight, their body fat content, their blood volume, you know, something else that might predict for how well that they handle that particular drug? So you can ask lots of different questions depending on what the biomarkers you're looking for. It's important, as I said, because it helps us distinguish which men are going to do well without a whole lot of therapy or gentle therapy, and which men will need a whole lot more therapy if we think that they might have more aggressive disease. It's also very helpful for discovering drugs as well, developing drugs. Now, you've probably all seen this graph before. It's a complicated slide and I might spend a bit of time on it, but this is typically what happens for men with prostate cancer. So if we look here, this is just an arbitrary scale, but this could be PSA. And along here is time. This could be months and years. So what happens is that after a while, if the PSA starts rising again, then we know that a man is not cured from their previous prostatectomy or radiation back here some years ago. So once the PSA starts rising, that must mean the presence of prostate cancer cells somewhere. So at that point, usually the man is extremely well, no symptoms at all. It's just that they've got a rising PSA. They get worried, of course, about this. But it means that there's cancer somewhere. Then they might have some local therapy, for example, some radiation, the PSA might fall a bit, and then it starts rising again some months later. When it gets to a certain defined level, hormones are started, androgen deprivation, and PSA falls fairly rapidly, practically down to zero, and then sometime later it starts to rise again. At this point, men have developed castrate-resistant disease or hormone-insensitive disease, and then they go into things like chemotherapy, docetaxel in this case. Then if they're lucky, it might respond, the PSA falls, and then eventually with time it starts to rise again until the patient succumbs from the disease. So you can see that over time there's actually a number of states or a number of scenarios in which you can do clinical trials. And it so happens that these are all shorthand for the new drugs that are coming along. And they're, at the moment, being studied after chemotherapy. Men who've failed chemotherapy might have enzalutamide or go on an enzalutamide trial or radium-223 or some of these other things. This slide is a little bit out of date. So, in fact, enzalutamide's been, the trial has been and done, and so is the radium-223 now, and they're available and in the US, and the FDA has approved them. Similarly, we don't have to wait until men have chemotherapy in order to do these clinical trials. We can say to them, okay, well look, what about targeting men who have rising PSA levels and the hormones are not working anymore? Why can't we do clinical trials in those men? And that's exactly what happens. So some of these drugs are brought forward and treated earlier in the disease to see whether they have just as much benefit in prolonging men's lives or maintaining their quality of life. And this is just the various names of stages that men might undergo trials. So biomarkers can be any biological measurement, as I said. It doesn't have to be urine or blood or even the biopsy base. It can be a physical measurement. It could be a blood pressure, could be body weight, body mass index, for example. But it gets more complicated because we can also look at the genes, of course, through the original tumour or from blood specimens, and then look at these various outcomes, proteins, RNA, metabolites, hormone levels, and you name it. It gets very complicated pretty quickly. But some of these might be better than others in terms of their ability to become a biomarker. So once we've discovered a biomarker, we need to validate it. Is it true? Does it work? Does it predict it all the time? And so we undergo various types of validation. The analytic validation is if you've got a machine that can detect circulating tumour cells, if you give it 8 different samples with the same blood, can it predict at the same time accurately the same number of tumour cells in that blood? So clinical validation is, so what? If you've got a count of 10 tumour cells or 20 tumour cells, so what? What does it mean? So then you have to go back to the clinic and ask, well, does a count of 10 mean quick, rapid regrowth of cancer cells? Or does a count of 50 mean that? You know, what if a patient has 0 circulating tumour cells, and so on? So all of those things need to be studied in the clinic as well. In prostate cancer, some of the key biomarkers, some of these are old, obviously, but very useful. Sometimes pain is a biomarker, elevated PSA we talked about. Survival is a very important biomarker, and that's the basis of many of these trials. So the FDA doesn't approve any of these trials usually unless you can show that your drug, your new Butte drug, is going to improve survival in men with prostate cancer. So those clinical trials need to be done. This takes a long time though, it takes years and years before the results of the clinical trials are released. So we're always looking for other things that might help predict that. In other words, other biomarkers. So PSA is an important biomarker, and this is from a famous trial from the Taxotere trial, the original Taxotere trial. Taxotere's chemotherapy in men who have failed hormones. And you can see that the men who had a very good response to Taxotere, where their PSA normalised, became normal, survived a lot longer than men where the PSA didn't fall as much. Okay, so if we take the 50% mark here and go along this line, and the corresponding survival is about 15 or 17 months with men where the PSA didn't fall as much as these other guys, this other group, where the survival was a lot longer, nearly 3 years, if their PSA became normal on Taxotere. All right, so this is a very clear biomarker for PSA. Any questions at this point? Yeah.
Yeah, I've just got one. It's about your trials, because, as you mentioned, enzalutamide has been approved for use in America, and yet we're still in the clinical or still in a trial stage here for that. I gather then that these drugs have to be approved by the approving authority in every country before they're released for general usage. Would that be right?
That's correct. Yeah. So usually the FDA is the first cab off the rank. All the pharmaceutical companies go for the FDA first, and then subsequently all the other countries are rolled, in turn, get submissions so that their drug is approved. And sometimes it's a very quick process, and sometimes it's a very slow process, depending which country you live in.
Yeah. FDA, is it?
Yeah, FDA is the Food and Drug Authority in the US.
Thank you very much.
That's right.
A lot of people use initials these days, and
Yeah.
I get nonplussed. I don't know what they mean, because they don't explain what they are.
Sure.
Yeah, okay.
So the FDA is very powerful. They approve all drugs in the US. So if you're a drug company and want to sell a drug, you have to get the FDA to approve your drug.
Here it's the National Health and Medical Research Council, isn't it?
No, actually, in Australia there's two bodies. There's the TGA.
Therapeutic Goods
That's correct.
Authority.
Therapeutic Goods Administration, which just has a look at the study, and if it's positive, they'll approve it. So what that means is that the company can then import the drug to Australia and start selling it. All right. Then the second step is to get it on the PBS. And so the second submission is through the PBAC. So that's the Pharmaceutical Benefits Advisory Committee, where not only do you have to show your drug's effective, but it's cost effective. So it needs to be below a certain price before the PBAC will approve it. Otherwise the government won't sign off on it, because it's heavily subsidised in Australia. That's the reimbursement system. So that's the reason for the delay. So in the FDA might approve it, and in the US there's no other system. Once the FDA approves it, the drug company can sell it. And then most of the time it's the person's health insurance company that pays for that drug. Whereas in Australia, 98% of us, 99% of us can't afford the kind of prices that they would sell the drug at just through the TGA. So we need the reimbursement system if it's going to be widely used. But that takes a few years and a lot of negotiation about prices and so on.
Would the costs in America be equivalent to what they are here, and the subsidy by the health funds the same as what government would pay here?
It's a very complicated issue, and usually drug companies, when they develop a drug, have an idea about how much they will sell that drug for worldwide. But there's always room for negotiation. So some countries will pay the amount that's been asked, and other countries will substantially lower the price that they're willing to pay. I mean, significantly lower. I'm talking about 60, 70% lower. It's not this fiddling around at the edges. So when it takes time to get drugs through a body like the PBAC, usually it's because the government has asked, exactly, we'll pay you 30% of what you asked for. So then if you're a drug company and you think, gee, it costs me more to make the drug than I'll get back, you have to seriously question whether you're going to push it in Australia or just make it unavailable. It's business, that's right. It's not viable otherwise, Yeah. So anyhow, that's the system. Now, just changing tack slightly, circulating tumour cells, it's a very hot new area in prostate cancer. The circulating tumour cells, all cancers, if you leave them long enough, start to try and invade the local tissues, and then some cells escape into the bloodstream, and then they circulate around the body. And the theory is that some of those cells, not all of them, will establish themselves somewhere in the bone or liver or lungs, and then become metastases sometime later. That's the theory. And over many years now, that's been the theory. We've never been able to prove it. But in the last decade, there have been machines that are now available that you can take a blood sample and look for this literal needle in a haystack. Because in 1 ml of blood, there'll be billions of red cells and billions of white cells and maybe 2 circulating cancer cells. So it's a very sensitive machine. The technology is amazing, actually, but it's now available, and it's still being researched. It's not clinical available because there are different types of machines, and we don't know the significance of whether one machine is better than the other. So it's a field that is very hot at the moment. We at Liverpool happen to have the only machine available in New South Wales and the second in Australia. So we've got ethics approval for that, and we're collecting blood, you know, from various patients with cancer to try and determine what this actually means. So,
You're doing research on that?
yeah, so we're doing trials and doing research on that to see whether we can actually. It's almost like a window. It's almost like a window. The opportunity to see what happens to an individual's cancer as time goes on, because it's easy to take blood. You can take a blood today and you can take it a month later and check the differences, particularly the genetic changes. So we hope that in the near future we'll be able to do all of those kinds of analyses. Highly, you know, restricted. Not everybody, not every hospital will be able to do that kind of thing. So circulating tumour cells, as I mentioned, they need to get into the bloodstream and then they go somewhere else, wherever they go. And the idea is that if you can take blood, then you'll sample that blood, and along with a whole lot of red cells and white cells and platelets, hopefully you'll capture circulating tumour cells, CTCs. Yeah.
Do healthy people also have CTCs floating around?
Now, that's a really good question. Those studies haven't been done. However, there are some patients with inflammatory bowel cancer that do have CTCs floating around. Just a few. Whether they're true CTCs or not, we don't know. It's hard to believe that they would be true CTCs. And it may be cells that just look like CTCs. So there's error in this measurement. And that's why we need to work it up and be careful about what the actual numbers mean. We don't want to be claiming someone's got circulating tumour cells when in fact it's just a bit of rubbish, or someone forgot to wash their hands, for example, you know, when they were taking blood.
Just following on from that,
Yeah.
I had a radical prostatectomy over 10 years ago, and my PSA is less than 0.01. Does that mean, you know, people say to me, oh, well, you're clear, you're clean. I never say it because I don't really know. Would I have some circulating tumour cells with a PSA that's unmeasurable?
It's a really good question. We don't know that answer. And these are sorts of areas that are ripe for research. We don't know that specific answer. That's the uncertainty that oncologists live under every day. So we don't know, all right? The best way, you know, people ask me all the time, of course, you know, am I really clear of disease? And I tell them, look, when you're 95 years of age, you can come back and see me, and then I'll tell you you're clear of disease, okay? In other words, time will tell, all right? And I can only do it in retrospect. So if you've survived 30 years from your radical prostatectomy, come and see me when you're 95. I'll give you some good news.
Just another question.
Yeah.
With your circulating tumour cells, if you discovered those in a person, perhaps somebody that had a radical prostatectomy, that would dictate perhaps the type of treatment that they have, wouldn't it?
Well, this is
would you deal with the blood rather than anything else?
This is the theory, see? This is why biomarkers are so interesting. If you discover stuff early, does it mean anything? But if you can find out that it does mean anything, and it's important and it's reproducible, then you can act on it very early. And so that's the advantage. You're absolutely right. So theoretically, let's fast forward 20 years from now. A man has their prostatectomy. 6 weeks later, they have blood taken for their circulating tumour cells, regardless of what their PSA is. And if it's present, it might be bad news. So then you'll think, okay, well, let's hit them with chemo or some new drug, that will be available in 20 years, or vaccines or something like that, That's exactly the point about biomarkers, so that you can distinguish more carefully, more accurately, what happens to these men. Yeah. So there's some of the early data about CTCs relate to the counts. So this data was generated from a machine called the Veridex, which has been around in the US for about 10 years. And if you've got more than 5 circulating tumour cells in 7.5 mils of blood, 1 tube of blood, that's prognostic in some cancers. In other words, it's not so good. If you've got less than 5, your prognosis is better. If you've got 0, prognosis is even better still. So some of those early studies show that kind of data. This is what a circulating tumour cell looks like. And if you can tell me where the CTC is, I'll tell you you're a liar. Because it's very difficult. So this is all the background cells. So they've magnified this particular area and using this particular technology and labelling these cells, different colours, you can see that some of these are actually CTCs. So this is a circulating tumour cell here. But this has been magnified, millions of times. All right. So that's the kind of thing that these machines can do nowadays. And in graphical form, if your counts are low to start off with, then with 1 year down the track or 2 years down your track post prostatectomy, the CTCs start rising, then maybe that means it's not good news, even before the PSA rises. That's the kind of implication, that's the kind of study that needs to be done, all right? Anything... Yeah, correct. I mean, but don't take what I say about CTCs as gospel, because it's just very early. This is cutting edge research. We don't know a lot about the CTCs as yet, but that's the kind of information that we hope to generate so that it's useful for our patients down the track. And this is the reverse. If your treatment shows that your CTCs drop with time, maybe you'll do better. That's what we hope anyhow. The beauty about this kind of stuff is that it may be more sensitive and give us better idea about what's happening to the cancer than just measuring the PSA. You might say to me, well, why not just measure the PSA? Well, the PSA will work fine if you're prepared to wait long enough, but it won't necessarily tell me the characteristic of your cancer. And cancers do mutate, they do change over time. So, prostate cancer 10 years down the track, once it's recurred, probably isn't the same as the prostate cancer that was taken out in the radical prostatectomy 10 years earlier because of the changes over time. So the idea is that circulating tumour cells might reflect those changes. And so you might be able to tell more about a CTC than a PSA level, or looking at your original tissue biopsy. That says the same thing. We can then classify patients as being favourable or unfavourable and correlate that with overall survival, especially in trials. The best place to study these things is in clinical trials because you're measuring a whole lot of other stuff in any case. So the advantages of CTCs might be they do change potentially before the PSA changes. It's quite specific for that individual's tumour, which would not be the same as the next man's tumour, and may reflect what's happening currently, even 10 years down the track. The disadvantages is it's hard to find, it's expensive at the moment, requires really very specialised lab, and there's still a whole lot of research that we need to do to be able to understand the disease. So CTCs can originate from the primary tumour itself or from the metastatic sites, and we can use this as a way to measure or re-biopsy men with prostate cancer without actually having tissue there. It's just a blood sample, what they call a liquid biopsy. Now, I'll finish up by talking about Abiraterone. Abiraterone, you will all know, is now approved following Taxotere, following the failure of Taxotere. So men with castrate-resistant prostate cancer need to have Taxotere in order to get PBS-subsidised Abiraterone. So that's the order that we treat patients with now if they happen to have metastatic disease. But the studies before chemotherapy have also been done and completed, and it shows that the extent of benefit is much more when you give Abiraterone. 8 months different between the no Abiraterone arm and the Abiraterone arm. Quite a lot of difference if you give it before chemotherapy as opposed to after chemotherapy, where there's only a more modest difference, not a 2-month difference, but actually 4 months difference, 3 to 4 months difference. And you might not think, oh, that's not very much, 3 to 4 months is nothing. But it's a misunderstanding. What they do is to quote the median value, the middle value, or the closest thing would be the average value, you know? And as you and I know, there is no bloke's average. We're all better than average, right? Agreed? So it fools people to thinking that you only get 2 months different. Well, that's not true. Some men get much less than that. Some men get no benefit at all. In fact, by definition, 50% of men get less benefit than a 2-month difference than if they hadn't had Abiraterone at all. On the other hand, 50% get a much more than 2-month difference. Okay? It's just the way that they count the statistics in a trial. So whenever you hear this, or whenever you hear doctors talking about the differences in median survival, it's really they're talking about the average patient, and they don't exist. You're either better than average or worse than average. It's just a notional thing. It's just a way, a shorthand of measuring how well your drug does. And all the regulatory bodies rely on this kind of data, on this kind of statistics. But it is a bit misleading unless you actually look at the whole curve. I showed you the curve before, right? The difference between men who had a drop in their PSA, quite a big drop in their PSA, versus men who didn't have quite a big drop. So you have a look at the whole curve. So it's possible that most of the benefit of Abiraterone is seen prior to chemotherapy rather than after chemotherapy. But this is not necessarily true because the trials were done at different times in different years. And as you know, over the last few years, there have been a whole heap of new drugs that have been developed. So trials that are done now are bound to show less of a difference because you've got second and third and fourth drugs that might make a difference. Whereas in the 5 or 10 years ago, there would have been far fewer drugs and it would have been easy to show a difference.
That's a chemotherapy type drug or a
no,
hormone or what?
Abiraterone is actually an anti-hormone. It's a pill and it blocks the way that your body handles circulating testosterone, okay? Whenever men start treatment with Zoladex or Eligard or those injections, those implants, the testosterone level drops significantly, about 90%, maybe 95%, but there's still a small amount of circulating testosterone. And if you've got prostate cancer cells that are sensitive to that, that's enough to drive the growth of the prostate cancer. So these drugs work a different way and block the production of that extra circulating testosterone. And there are other drugs like enzalutamide, which block the surface activation of testosterone. So they work at the cancer cell surface, at the receptors, and block it. So you can cut off the production of testosterone mostly, then you can block the body's production of testosterone, and then you can also cut it off where it's supposed to act. So theoretically, if you add drugs which act at different sites, you should get a better result than if you didn't use them in combination.
Are they doing trials on enzalutamide and abiraterone together at the moment?
Yeah, so there are lots of ongoing trials, many, many ongoing trials at the moment, and one of them is the combination of enzalutamide and abiraterone. But the reality of the politics is that they're both made by different drug companies. So you're not, you know, there'll be a certain amount of cooperation, but only so much. So really, I think that's pretty much all I had to say.
Thank you.
I would like to summarise by saying, look, this is a very interesting disease, and there's lots more that we need to know and learn about and research. And I've just covered just a tiny little bit of it, including just a little brief discussion about circulating tumour cells and also other biomarkers as well, and what we try and do, quite apart from the new drugs that are being developed and the trials that are ongoing. And I'll leave it at that.
If somebody wanted to be tested to see whether they had any circulating tumour cells, how would they go about it? So that's all the neurotic and paranoid in the group. How can we get satisfaction or the bad news?
Well, first of all, we could do it at Liverpool Hospital. There's no problem. All it needs is a blood sample, and then it would just be processed, and we would get a number 24 hours later, approximately, a couple of days later perhaps. The difficulty is knowing what that number means, and we won't be able to tell an individual about what it means. So if your number came back at 17 cells in that tube of blood, someone else came back at 54, I wouldn't know what that meant. Ordinarily, based on this kind of literature, you'd think, oh, the bloke with 54 would do worse than the bloke with 17, but not necessarily, because it needs to be compared with that individual's own cancer and its Gleason grade and how quickly it's been there and whether it's come back and whether it's hormone insensitive or not. There's a whole lot of factors that need to be taken into account.
So people wouldn't have had a certain happening beforehand. For example, they wouldn't have had to have a rising PSA or anything like that to go through your program?
No. But that makes it even harder. If you've had radical prostatectomy and your PSA is even 0, I've no idea what anything would mean if we happen to find 2 circulating tumour cells. You know, you'd have to wait until you're 95 to find out what that meant, you know. And so what we're trying to do this is on a systematic basis. So we would like to collect, 50 men with hormone or castrate-resistant disease, take a whole heap of circulating tumour cells and get a feel for what the numbers mean. But it's more than just numbers. What we're trying to do is also individually pick those cancer cells and find out whether they just happen to be partners and just floating around, or whether they're the ones that are very aggressive and that they're the aliens being sent out from the mothership to establish colonies somewhere else. We don't know that. And so if we can, do the genetic profiling on those single circulating tumour cells, fabulous. We might be able to learn a whole lot more about the behaviour of prostate cancer,
With a cancer that's spread, does it have a signature? For example, if you detect a cancer in the lung, does it have the signature? You can take that cells from that and say, yes, that's prostate cancer. And if so, does it have a signature of what kind of prostate cancer, like a Gleason 9 or whatever?
That's a good question. And at the moment, we do have those things available, and those tests are done by pathologists. but it's pattern recognition. So you take out that thing from the lung, the pathologist looks at it, and because they've seen, 1,900 prostate cancers before, they think, this is prostate cancer, even though it's come from the lung. So the pathologists are very good at that. They'll be able to tell you the histology. But what we're also appreciating is that sometimes those things are a little bit vague. It looks like a cancer, but you're not sure whether it's kidney cancer or prostate cancer or bowel cancer. It's what we call de-differentiated or a little bit undifferentiated. And in that situation, that's where the genetic profiling could become extremely useful. So if we do find a signature, as you say, spike in this and drop in that and another spike in this, then we might be able to recognise it as a prostate cancer.
So presumably that would have implications for the survival of the patient. Some kinds of cancer are more aggressive.
Yeah, true.
What it was.
True, but you can tell that usually from clinical details anyhow, because prostate cancer doesn't normally go to the lung. If you see a man with a history of prostate cancer and it's in his bones and in his liver and in his lung, you're in trouble. Exactly right. You don't need a whole lot of genetic profiling or genetic testing to be able to tell that. That's exactly right. It's the pattern of what happens.
With a radical prostatectomy, the PSA is continuing to rise after that. Does that mean the CTCs are also rising or not?
We don't know that information yet. Presumably, yes. Because the PSA is produced by prostate cancer cells, so the more of it means there's more cells, roughly, proportionately. But that doesn't, because we don't know at what stage, we don't know a lot about the circulating tumour cells, whether it comes early and then tails off, or whether it appears late in the disease and just happens to overwhelm the blood. I don't know. So it's possible that circulating tumour cells are just passengers, all right? Maybe they don't have a role at all in establishing colonies. Maybe, after a while, if you've got enough cancer cells, they just simply spill out into the circulation,
So with a rising PSA, then that means that what happens next?
Well, eventually, if you wait long enough, with a rising PSA post-prostatectomy, you'll see that the prostate cancer has recurred somewhere. You'll need to do a bone scan and a CT scan to find that out, but eventually, yes.
Yeah, my bone scan was clear. They thought that from the biopsy, probably at the neck of the bladder or something like that.
Yeah. Sometimes you can't tell.
No.
A man might have rising PSAs and you do your scans and it's all clear.
So do they treat it with radiotherapy or chemotherapy? Or
No, because if you can't see the disease, you can't irradiate it.
Right. Okay.
All right. Similarly, if you can't see the disease, I think most oncologists would be a bit nervous about giving chemotherapy at that point. There's not enough proof.
How do you see it then?
Well, if you wait long enough, eventually, you just wait.
Oh.
Yeah.
Okay, thank you.
So the question begs, if you identify one of these floating cells, even if there's only 2 in a 5 ml syringe, can you tell by examining the structure of that cell where it actually came from? No, when we don't know where, we've got a rising PSA and we don't know where the primary is, will that little cell tell us?
Probably not accurate enough. You can put a roadblock on the Pacific Highway there and pick up a whole heap of cars, and you can even tell the passengers in it, how many there are and what they're doing in the car, but you can't tell where they were driving from. It's the same kind of challenge. And don't forget, these things are cells from your own body. So the genetic makeup will be almost identical as your original prostate. Not the same, because they change and they mutate.
I would have thought that if the prostate cell landed in the liver, that it would take on some of the characteristics of that liver cell. And when you looked at it, you could see a twin message there. Hey, your prostate and your liver. That's not differentiated enough?
Most of the time that doesn't happen, at least as far as we're aware. They're quite different. There may be a role, though, for an interaction between the liver cells, the supporting structures, and your prostate cancer. So all cancer cells that circulate don't survive. In fact, most of them don't survive because it's a harsh environment and they've got to make it through, the heart and arteries and veins and so on. They don't survive, they die off. So the fact that you've got circulating tumour cells doesn't necessarily mean that you're going to get metastases. In fact, most of the time you don't. And that's also another factor to throw into the equation as well. So if your circulating tumour cell ends up in the liver may well decide just to eat it up, okay? And it wouldn't survive. That'd be the end of it. It would just break up and be absorbed. It wouldn't necessarily establish a relationship.
As a general rule, what would you recommend the repeatability or the period for testing PSA after you've had prostate cancer and it's been removed? Would that be annually or every 6 months or?
That's not a question I'm usually asked. It's not a question I usually have to deal with.
Fair enough.
The urologists will have differing schedules, if you like, or policies. But I think that also depends on the individual as well. If you happen to have a low Gleason grade prostate cancer that's been removed, I don't know that you need to have a whole lot of PSA testing afterwards. Usually annually you'll be fine, or in that sort of situation. If you've got more worries or more concerns, you might want to get tested more frequently.
Oh, thank you. Yes, I go annually. That's a sort of.
Yeah, so
I've been doing that for 15 years.
It's there's a wide range of variability.
On PSA, PSA can be partly caused by other things apart from cancer, like BPH and prostatitis. So if you've been treated and cured of prostate cancer, can you not still have PSA due to these other causes?
You could, except that if your prostate's been taken out, then there is no enlarged prostate and there is no prostatitis.
I mean, I was thinking more in terms of radiotherapy.
Yeah, sure. If the prostate's still in situ, you're not sure what the contribution of that PSA is to whatever surviving tissue is. That's why we follow the PSA, we follow the trend, So if it's just an enlarged prostate cancer and the PSA doesn't really move much and it's fairly stable, even if it fluctuates, then it's not likely to represent cancer. But if it goes like this, then it likely to be is.
I mean, could it not be prostatitis in that case?
It could be, but usually PSA doesn't rise that much with prostatitis. There's a lot of overlap, and that's why PSA is not not great in certain situations.
No, thank you, Paul. That was a terrific presentation. Many of us have been coming here for many years and we've seen many presentations. But that was very different and very enlightening, and as you say, you wanted to make it conversational and interactive, and you certainly did that. I think that everyone will agree that was an absolutely terrific presentation and really enlightening. Thank you very much indeed for coming.
Pleasure. Thank you very much. Thank you.